It's just they don't have it. It's just obstructed. Stuff's not coming out. Failure to thrive would be because they can't absorb, right? They have malabsorption. They're eating like they should, but they just cannot absorb because they have that thick mucus all in their GI tract. They're not releasing those enzymes to break food down to absorb it appropriately. So they're little, skinny, not at the right height, failure to thrive. You'll learn more about that in peds. Intussusception is whenever you have a piece of your bowel, small intestines, it's a long tube, and it can go into each other and then pop back out. That's what, in a general, easy way of saying it, that's what intussusception is. The bowel goes in and comes out. That's because all that thick mucus gets on the inside of it, and it gets just kind of funky, and it'll move inside and come out. Intussusception is really a serious thing, especially it's a little baby issue. Rectal prolapse. Here's the whole pancreatic insufficiency. Because you already know what your pancreas secretes. You cannot, it no longer secretes fat-soluble vitamins. And that again, is kind of the same thing here. That's why you are unable to digest or absorb fats, proteins, and carbs like your body normally should. Abdominal pain, abdominal distension, jaundice, GI bleeding. These are some of the other things, GI manifestations. Respiratory tract manifestations. Gotta hurry. Cough. Post-tussive emesis. Basically, a lot of stinking lung issues. I know several asthmatic, or kids that they were diagnosed with asthma, and then they tested them for cystic fibrosis, and that actually was what was going on. Because if you look at that, does not a lot of that look like asthma? Wheezing, dyspnea, that's whenever you can't catch your breath, short of breath, coughing, that's asthma. You would totally think asthma until you were like, I've thrown every asthma med known to man at this kid, and it's not getting better. And again, this is where your differential comes into play. Because if you think just asthma, and it's not getting better, you need to understand what else on my differential can present just like this. Lots of lung stuff, read that. Urogenital, it does a lot with the testes, the reproductive organs. So males, they do not have a vas deferens, it just does not do what it's supposed to do, or it's not there. So they have issues, obviously, with infertility. They may have issues with undescended testicles or hydrocele. That's where you get a little bit of fluid on the testes, which by itself is not a big deal. My son actually has one. It's the weirdest thing. But in the face of this and other issues, you would think, I need to look at something else. Females, they also have decreased fertility. This is basically just kind of going back over what I just said to you. Chronic respiratory infections. So bronchitis, there's bronchiectasis, pneumonia, atelectasis, because they just have this chronic inflammation and mucus production. And like I was telling you before, if you have mucus that sits around anywhere for very long, it becomes stagnant. Just like a puddle can become stagnant. It's gross if it's been sitting there for a long time. That's what's happening inside these people, especially their lungs. So that sets up shop for a bacterial infection. Pneumonia. Hemoptysis is when you cough up blood. Pneumothorax, because their lungs become so scarred and diseased, they can actually, essentially, burst, pop. Pneumothorax is when you drop one of your lungs. You'll get electral pneumothoraxes. Hypoxemia, low oxygen, hypercapnia, increased CO2. And that's because all that thick mucus, they can't get O2 in, can't get it to their blood, and they can't, remember yesterday in Robbins, can't get the CO2 out because of that thick barrier. So it builds up inside their body. Infertility, yeah, we already went through that. They do have increased electrolytes in their sweat, and I'll get to that in a second. This is, if you're a mnemonic person, I was not in school, but this is like the famous mnemonic for cystic fibrosis. If you want to read this or memorize it, you can. C, pancreas. I don't know. But it's kind of like the most, have you heard the word pathognomonic yet? Has anybody used that word with you? Pathognomonic is like, this is absolutely associated with this disease. So these are like the pathognomonics for cystic fibrosis. Clubbing of the fingers is a major pathognomonic sign of cystic fibrosis, and I have a picture of that. The electrolyte, or the elevation in the sweat, the reason for that is all that sodium's trying to get in there. They will actually have this increased salt content, and their skin is salty because of it. It's really cool. The sweat, when they sweat, they'll have increased salt in it. We went over that. If they do get a secondary bacterial infection, staph or Pseudomonas is the two big bugs that you're going to see them infected by. Staph is early on, Pseudomonas is later, or Pseudomonas is most common. That is, and you don't have to know bug antibiotic coverage to know what to cover those. Dan will go over that. This is just a nice little picture of all the different organ systems that it affects and what it does, if you like pictures. There's the thick secretions that it looks like. Physical exam, runny nose. People with cystic fibrosis, oddly enough, have nasal polyps. That's kind of pathognomonic for cystic fibrosis, is nasal polyps. There's all your pulmonary signs. We've already went over those. Increased AP diameter of chest. That's basically if you turn someone sideways, their chest is bigger. And that's because of all the mucus and the air trapping inside their lungs. GI tract, we've already went over this. They have a lot of deficiencies, vitamin A, B, D, E, K, and all the things that causes. There's the clubbing of the fingers. Do you see how they're like over, like they just kind of club over? That is a pathognomonic for cystic fibrosis. So again, when you go to start trying to memorize this information for testing purposes, you pick out the things that make it way different than a cold or a URI, or basically what I said a while ago. These are things that you would have to put in a test question for you to go, oh yeah, on physical exam they have clubbing. I think I know what that is. Does that help? This is what you've got, how you have to start thinking about these things. So diagnosis, you do a sweat chloride test. You have to do it, this is pretty basic, you have to do it twice. And I've heard different things from pulmonologists at OU. It's either on the same day or you can do it on 2 separate days. But you have to do a sweat chloride test. If it's greater than that number, 60 millipose per liter. Oh, there it is. I think that bulletin, it must do 2 tests on 2 different days. I actually had a student who argued that, and that we had a pulmonologist tell us that there are some people that they do it on the same day. Did somebody raise their hand? I thought somebody raised their hand, sorry. So this is something you would obviously need to memorize, right? If it's greater than that number, and physical exam findings consistent with those 2 together, there's your diagnosis. You can do pulmonary function tests. Cystic fibrosis is considered an obstructive lung disease, When you learn PFTs tomorrow, you'll understand way better what restrictive lung disease versus obstructive lung disease is. I'm not going to, because it would confuse you today. So just keep this in the little back burner. Cystic fibrosis is an obstructive airway disease. You can do an ABG. ABG, Dr. McNeil will go into more. That's arterial blood gases. Because they can't get oxygen in, they obviously have low O2, right? This is when you take this little test. You look at all these different components. You look at the blood for oxygen level, carbon level. Is their blood acidic? Is their blood alkalotic? Increased CO2 in the body causes you to become more acidic. So if you're holding on to CO2 in your body because you can't get it out, you can't breathe it out like you normally should, what do you think your blood's gonna be? Acidic. So there's just maybe a little down and dirty of ABGs. He will, of course, get into that more. But that's what an ABG is, arterial blood gas. Chest x-ray, here's that bronchiectasis. There's hyperinflation, increased pulmonary markings, and bronchiectasis. And I'll tell you what that is in a minute. You can look at their pancreatic function. You can basically see, are they secreting those soluble, those vitamins that we need to break down stuff? Oh, my stomach's growling. But you can also collect feces from them and see how much fat is actually in their feces. And there's a test for that. Yes, ma'am.
In the pathognomonic CF pancreas, it says that one of the A's is alkalosis, which doesn't that mean basic?
That does mean basic, and I actually don't know, I threw that mnemonic in there. I don't know why that alkalosis is there.
So it is acidic though?
Well, if they're holding on to CO2, they are.
Okay.
I don't know why that's there. Disregard that for now, and I can find out why. So, if you're thinking about like lab med, you know, Dr. McNeil's giving you an ABG lecture, right? That's pretty much it for lab med. If I gave you a question on what is the diagnosis for cystic fibrosis, is it A greater than 20, A greater than, you get what I'm saying, on a sweat chloride? That would be considered a lab medicine question. Do you understand how that works? Mm-hmm. Okay, I just want, because you're only going to get one lab medicine, you're probably thinking, how's that even? So I can write a lab medicine question for you, lab med question. And this would be a great example of one. Here's a chest x-ray of cystic fibrosis. Hyperinflation, this is normal on the left. Oops, sorry, I just went the wrong way. All that increased pulmonary markings. I would not put a chest x-ray up and say, what is this? What disease is this? Because that could also look like about, 10 other things. Not so much pneumonia. Pneumonia, you'll get some pneumonia x-rays. It's like this very defined, it looks like you took a white piece of paper and stuck it over one of the lobes. It's there's consolidation or fluid in one lobe of the lung. You'll get some pneumonia pictures and you'll be like, or a haziness over just one area. See how this is kind of diffuse? Yeah. Okay, so what is bronchiectasis real quick, because we're going over. Basically what happens is you have airways in your lungs. You can read this on your own. Because of all that mucus and that inflammation, it's all the time there, which it shouldn't be there. So those little airways are always inflamed and full of mucus. Over time, they start to lose their elasticity. They're not strong little tubes anymore. They kind of get flabby and loose, and they become bigger. That's technically what bronchiectasis is. It's not a disease on its own. It's because of all the inflammation of the mucus that's in their airways. They become widened. Did they even use the word flabby? Yeah, flabby. That's weird. And you can read that there. But that's what bronchiectasis is. I know it's technically one of your medical conditions on its own, but it's not really it's a issue secondary to a medical condition. There's a picture of one. So if you did a CT scan, where they take little slices through things, this is what it looks like. It looks like a little Cheerio or a round. Here's just another picture of it. Here's all the other conditions that can also cause bronchiectasis, cystic fibrosis being the most common. And this is why, because you get all that inflammation, all that mucus, and it's stretched out, and it just stays that way after time. It can only stay in its normal anatomy for so long. Treatment, I'll let you go through this on your own. Physiotherapy, they will actually, you can order physiotherapy through physical therapy, like put in a physical therapy order or referral. It's where they beat on the chest, and it helps people get stuff up out. Anybody in RT here? This is where- It's where they help get stuff up. Exercise, bronchodilators. Eucalyptics get stuff up. You can give antibiotics if they obviously have an infection, right? I'm not gonna ask you to know any antibiotics for that. There's actually an inhaled recombinant human deoxyribonuclease. You can actually inhale that. It's super expensive, but it is a prescription. And it actually helps reduce exacerbations. Not a lot of people can afford that, but there's actually that out there. Lung transplant. How many people get lung transplants? Vaccination's really important. They need to be vaccinated against everything because they are at major risk for lung infection. Nutrition, obviously, because of all the, they don't have those enzymes that we need to break stuff down. You've got to replace that. And you can. There are replacements for any one of the pancreatics, and there's a replacement for any vitamin, as you probably already know. You probably take vitamins. And it still may not even work then, so you have to give them extra of it, of those vitamins, of those, the pancreatic, the enzyme and the vitamin supplementation. So high calorie diet. Obviously genetic counseling, whenever you go to have a baby, they're gonna do that with you to tell you this is what could possibly happen. And then lung transplant. And it is the only, obviously definitive, for the lung portion of cystic fibrosis. Outpatient care. There's actually a cystic fibrosis clinic at Oklahoma, at Children's. Janice Lynn, the young lady that was going to come speak to you today, that's what she does. She works in the asthma and cystic fibrosis clinic. I know, it's been awesome. But that is important. These people stay very close in contact with their pulmonologist or their PA that's in pulmonology. And they do 2 to 3 month follow-up. As you can imagine, you would also need to get your pediatrician involved in this as well, because these kiddos are going to be closely monitored for their well child checks, because they are going to be smaller, they're going to be underweight. So a lot of coordination of care or coordination between pediatrician, pulmonologist, primary care doc. And then obviously addressing psychosocial issues. That's really important because these kids are sick, and that's really hard if you've ever had a kiddo that's sick or have a family member, it can be very, very, very difficult, and given their life expectancy. Any questions over cystic fibrosis? That was really thrown together. I'm sorry for that. Yes, sir.
The alkalosis I found.
Okay, go for it.
It says it's maintained by excessive sweat, sodium chloride losses.
Okay.
So.
Maybe that's, if it becomes so diffuse in the lungs, the hypercapnia because of the mucus, but that would probably be for the, did you hear that?
Yeah, I found another thing that said it has to do with the chloride balance in the kidneys, that it affects the aldosterone secretion, which in turn sounds very involved, is what I got out of it.
The hypercapnia comes because of holding on to CO2, and which is acidic. Guys, I really appreciate your being flexible with me today and coming back in at 10. I know some of y'all wanted to go shopping. Or not, blame you.
Who said that?
Go have some lunch, and then you'll come back and have another lecture. And of course, if you have any questions, come up to my office. Oh, I was going to give you all my cell too.
I'm gonna go out and
Yeah, everybody, if you have cash, make sure you give it to Meredith. She pays her own money.
You guys have my cell number.
Wait, cash for what?
I meant to give that to you the other day, but Dr. Neal's making me nervous.
Wait, Shelby, what are you giving Meredith?
I guess we could probably,
I'm going to come tear you up.
Huh.
okay, it's like $2.
Yes.
So I'll go take my
I know that it's like,
Everybody,
Yeah, I'll just